Last speaker, last but not least, is Dr. Catherine Stika, who's a clinical professor of obstetrics and gynecology at Northwestern Feinberg School of Medicine in Chicago. Welcome, Dr. Stika.
Good morning still. So I'm an obstetrician at Northwestern, and I'm going to, even though this is talking about the impact on peds, I'm actually going to turn this back around and present it more from the mom's perspective and bring it a little bit more basic pharmacology back to our talk. So how did this thing go? What do I push on this thing? There we go. Oh, so it's been pushed so much you can't see the forward button. So I have no conflicts of interest. My goals today are to talk about how critically important it is to involve pharmacogenetics in any kind of analysis that we do. Especially with work with SSRIs, the data is all over the place, and only with trying to stratify it by pharmacogenetic phenotypes are you able to see anything that's going make any kind of sense out of it. And I'm going to use both the data from our Optimum study, which was a PK study of SSRIs in pregnancy, and I'm going to focus on our results for sertraline and citalopram and escitalopram. And then I'm also going to use the same kind of, showing how pharmacogenetics can really facilitate interpretation of data with our 4-probe cocktail study that we did, which was a subsidiary study to our Optimum. The other thing that I want to talk about at the very end is that in the beginning, 3 decades ago, our biggest struggle was to say, giving a drug to a mom, it's not just exposing the fetus. You really have to look at what's going on in the mom. And we finally got pregnancy to be accepted as a special PK population. Right now, I would actually think another challenge is when you think about drug exposure, it's not just the potential teratogenic effects on the kid, it's not just the mom's PK, but it's also how does that drug affect the pregnancy unit itself? And not all drugs do that, but especially when we're talking about SSRIs and the serotonin drugs, you have to also look at the interface between the mom and the baby when we're trying to figure out what's happening to that unit. So starting with our Optimum study and the importance of pharmacogenetics. So Optimum was a prospective longitudinal observational cohort study. It was the prior iteration of, it was the OPRC before MPRINT. We had 3 academic centers and a rural health center that contributed patients. We enrolled pregnant patients who were clearly diagnosed with major depressive disorder. They were stable at the time, both in terms of their symptomatology, and they were also stable on the drug that they had chosen to use. There were also people who, independent of the study, had elected to continue their SSRI during pregnancy. And the drug itself was managed by an independent practitioner. So when the dose got changed, why the dose got changed, what kind of counseling was done by people outside of the actual study. What we did do is we sampled them every 4 weeks through delivery, and then approximately 6 weeks postpartum, and then distant postpartum, 14 weeks, which would represent the non-pregnant state. We did a 24-hour post-dose to represent the trough, and we, as people have talked about, you do concentration to dose ratios, and that's a way to standardize comparisons both between people who are on different doses, as well as to standardize it when a dose change occurs within the same participant. And then we did DNA pharmacogenetics for 2C9, 2C19, 2D6, and 3A5. So starting with sertraline. Sertraline has a very complex metabolism. It's the demethylation process can occur through a number of different drug metabolizing enzymes. The dominant ones are thought to be 3A4, 2C19, and 2B6. And then there's also some additional energy put into it from 2C9 and 2D6. And we know from other studies that have occurred in the last couple of decades that 3A4 clearly goes up, its activity in pregnancy is induced, that estradiol turns off transcription of 2C19. 2B6 is a bit confusing right now. People thought that it was going to go up, but with certain clinical studies, they haven't been able to show that activity of 2B6 consistently is increased in pregnancy. 2C9, it definitely goes up, as well as 2D6, which outside of pregnancy isn't usually induced, but it certainly is in pregnancy. And then I'll be talking about the escitalopram metabolism, which is a little bit different. It undergoes two demethylation processes. The first one, to desmethylcitalopram, involves 2C19 and 3A4 with some help from 2D6, so it's a very similar but slightly different composition of enzymes. And then there's the second demethylation process, which is catalyzed only by 2D6. So for sertraline, we had 47 participants. They were on a wide range of daily dosages, as you can see. And this is our spaghetti graph. This is showing how crazy, this is concentration to dose ratios across pregnancy. Delivery occurs with those two, at the two red lines. And you can just see this unbelievable inter-individual variation that we classically see with SSRIs. So we had about a 40-fold difference between concentration to dose ratios in antepartum, a 15-fold postpartum, and this is really consistent with non-pregnancy data where you can see as much as an 88-fold inter-individual difference in concentration to dose ratios. When you try to simplify that and make it a little bit more in terms of you're looking at the means and the medians in this whisker chart, and once again you can see the delivery is this two vertical red lines. The distant postpartum would be the non-pregnant state, and what you can see is that compared to pregnancy, where it was pretty much stable across pregnancy, despite the wide variation compared to the 36 time point. And this was our study was powered to look at, this was our primary comparator between the 36-week time point compared to distant postpartum. And what you saw was about a 22% difference that was statistically significant between these two time points in terms of increased metabolism occurring in pregnancy. And then when you looked at the metabolic ratio of sertraline to desmethylsertraline, you could see that it very slowly decreased across pregnancy, but you still had that very significant 38% difference between distant postpartum and the end of pregnancy. What's interesting though, when you look at that data, you're struck by two things. One, this marked inter-individual differences, but you also see that there really doesn't appear to be that much difference between what's happening non-pregnant compared to what's going on pregnancy. However, when you stratify your analysis by pharmacogenetics, you begin to see a completely different picture. So if you look at the phenotypes for 2C9 and 2D6, and what you can see, the normal and the ultra rapid, the normal are in green in both of these, and the ultra rapid are in brown, and then the poor or intermediates are in blue. And you can see they just sort of interweave over each other. They reflect the overall changes that we see in pregnancy compared to postpartum, but nothing really sticks out. However, when you stratify it by 2C19 phenotypes, you see a completely different picture. And once again, you can see the rapid and ultra rapids are in brown, the extensive phenotypes are green, and our poor intermediates are in blue. And we had 6 intermediates and one homozygous poor 2C19 metabolizer. And here, in terms of this particular group, there's a fairly substantial change between distant postpartum and that 36-week time point. And when you kind of clean it up a little bit cleaner visually, what you can definitely see is in the postpartum period, this really reflects what's generally known, what's generally recommended by CPIC in terms of what to expect when you're giving somebody an SSRI, when you're giving sertraline poor 2C19 metabolizers, that the concentration to dose ratios are much higher in the non-pregnant state. And you can really see that in this data here. And that compared to our primary comparator, which was at that 36-week point, it was half the concentration to dose ratio for the 2C19 poor metabolizers. I mean, granted, it kind of floats a little bit above that, but it essentially at the 36-week time point, the poor metabolizers and everybody else have roughly equal concentration to dose ratios compared to that distant time, the non-pregnancy state. And when you separate them out and look at them, you can really see the differences between the rapid, ultra rapids on the far right, the normal metabolizers in the middle, and then the curve for our poor intermediates with a 2C19. And so we can explain this by that the decrease in metabolism that occurs in the people with some part of functional 2C19 is during pregnancy by it being turned off by transcription being turned off by estradiol is countered by the increase in metabolism that occurs with 3A4. It's kind of like, a teeter-totter where they balance, the changes balance each other off, and there's essentially then no significant change between non-pregnant and pregnant for people with functional 2C19. However, in your intermediate or poor metabolizers, which have either no functional 2C19 or impaired or partial 2C19 function, the changes in 3A4 dominate. And what you see is that's what accounts for that significant drop in their concentration to dose ratio in the poor and intermediate metabolizers. Citalopram and escitalopram. Citalopram is a racemic mixture of R and escitalopram. Escitalopram is marketed as its own drug, and we had patients on both. The escitalopram is considered the active moiety, and it's 167 times more potent than the R, and none of the metabolites, even though they have partial, really, their activity pales. So the most important thing to look at is what happens to the escitalopram. We had 30 participants, 9 were on citalopram, 21 were on S. These were their dosage ranges. And this is a little bit neater, the spaghetti graph, looking at their concentration to dose ratios across pregnancy for escitalopram. And when you clean it up and you look at it, once again, you can see that the non-pregnant state compared to the 36-week mark was about 26% lower, statistically significant. When you separate out the phenotypes, once again, 2C9, 2D6 really doesn't impact or show up anything differently. But when you look at the 2C19, the poor metabolizers, excuse me, let's start with it. The extensive and the rapid, the normal and the rapids are essentially no change. It's flat across pregnancy and non-pregnant. But when you add in, we had just intermediate metabolizers. We didn't have any poor metabolizers in this group for 2C19. What you can see that is there's a 36% drop between distant postpartum and the 36-week time point. And once again, the same explanation in people who have functional 2C19, it goes down, 3A4 goes up, metabolism is stable, as opposed to the people with a poor intermediate, where they don't have that change to buffer the dominant increase in metabolism that occurs because of 3A4. Our molar ratio for the next demethylation, when you're looking at the molar ratios between DCIT and didCIT, what you can see is that it's catalyzed by 2D6, which is known to progressively increase in pregnancy. And you can see that in the progressively lowering of our concentration to dose ratios, and that there was a 46% difference between the end of pregnancy and distant postpartum. So I'll take a sip of water before I go on. So all that stuff has all been published. This is next phase of our publishing of this data. So we did a cocktail study, a probe cocktail. So there's been one other probe cocktail study done in pregnant that's been published. It was done out of McGee using in the very first iteration of the OPRU. And they looked at caffeine for, they gave pregnant people both caffeine as well as dextromethorphan. Ever since then, although we've looked at individual probe drugs, no one has given a cocktail to pregnant people since, but we did. And what we wanted to do is we used drugs to reflect the dominant drug metabolizing enzymes that were involved with our SSRIs. And so we gave them dextromethorphan, 15 milligrams is a half usual dose, omeprazole for 2C19, which is on the low end of that dosage range, midazolam 2 milligrams orally, which is about 10% of the maximum pediatric dose, and then talbutamide. Talbutamide, you may not be very familiar with that drug. It's not used very much. It's somewhat hard to get, but it's an anti-glycemic that is a probe it's a decent probe for 2C9. Clearly the best probe for 2C9, which is warfarin, which is the most, not best, but the most commonly used, we're not going to be able to give to people in pregnancy. So we did give them talbutamide, and we gave them to the people that had 2C9 involved in their metabolism. And then what we did is we did a 6-hour AUC for midazolam. We looked at omeprazole metabolic ratio at blood drawn at 3 hours. With the dextromethorphan, we collected a 24-hour urine. And then for talbutamide, we checked a 4-hour glucose, and just to be on the safe side, because we don't want to make any of our pregnant patients hypoglycemic. And there was no significant change in their sugars, but we're all prepared to give them something just in case there was. And then we looked at the talbutamide concentration at 24 hours. And what you see in terms of starting with midazolam, this parallels exactly what Mary Hebert out of UW found in the very first midazolam study in pregnancy, that 3A4 goes up in the third trimester compared to postpartum, and our AUC was about 50% smaller during pregnancy. When we had one person who was, we had one person who was a 3A5 intermediate metabolizer, and her AUC was actually had decreased greater than what we saw for the mean for the other four. So 3A5 is involved in the metabolism of midazolam. As to whether it goes up in pregnancy, I have not yet found a good reference for whether 3A4 is induced as well as whether 3A5 is induced as much as 3A4 is in pregnancy. Looking at talbutamide, when you looked at all of our subjects together, and I think it's important to stress that we only had 6 people. Not many people wanting to take extra drugs when they're pregnant, even for the sake of helping the study. And one of those people did not come back for her postpartum. But because we had such an incredible spectrum of pharmacogenetics in here, we were able to see some really interesting results. So talbutamide for 2C9, we'd expect it to go up, and we saw that. If you look at the normal metabolizers, which are in turquoise, you can see them on the right. What's interesting is that of our 2 intermediate metabolizers, one of them was a star 3, star 1, star 3. The other one was homozygous for star 2. And what's interesting is both of those alleles are considered loss of function with regard to warfarin, but with talbutamide, star 3 has a loss of function, but star 2 doesn't. And so you can see in our homozygous star 2 that she's actually, at least postpartum, functioning very much like the other normal metabolizers for 2C9. With omeprazole for 2C19, if you just looked at the composite change, knowing what we know about 2C19, it's turned off. You'd expect metabolism to be less in pregnancy, but if you looked at the composite, we actually saw that it was lower during pregnancy, that the metabolic ratio implying that metabolism had gone up, which made no sense until you looked at the pharmacogenetics. And if you, starting with on the right with the green, with the normal metabolizer, you can see how, as you'd expect, there was less metabolism during pregnancy, as well as the rapids. I mean, they did it better, they're more efficient, but they also showed a decrease in metabolism during pregnancy. The only weird outlier was our intermediate metabolizer, who you would expect, as in postpartum, their concentrations to be higher, but it turns out that person was on fluoxetine. And fluoxetine strongly, it inhibits, it's a moderate inhibitor of 2C19. And so what you're seeing isn't the effect of 2C19 on that person, but you're seeing the alternate pathway, that omeprazole can also be metabolized to 5-hydroxyomeprazole by 3A4. And so once again, you're showing that when fluoxetine turns off 2C19, you're seeing the effect of 3A4 on that, and the metabolism is increased paradoxically in that one person. Then with dextromethorphan, dextrofan ratio, everybody was pretty similar in this. 2D6 goes up in the third trimester, and you can see in all of our different phenotypes that it goes down. But the weird outlier is that the ultra-metabolizer you would have expect, the normal metabolizers are in green on the below. You'd expect to see the intermediate ones slightly higher than that, but then why is our ultra-metabolizer so poorly functioning here? And it turns out that person was on fluoxetine, which strongly inhibits 2D6. So even though 2D6 increases in pregnancy, its metabolic ratio is much higher. It's sort of in the inverse position. And the one person who only did it antepartum was actually turned out to be a 2D6 poor metabolizer. And whereas all of these other ratios, the highest ranging from 0, almost 0, to 0.6, her metabolic ratio was 8, because she essentially could not metabolize dextromethorphan. So the question then is, would doing pharmacokinetic analysis for 2C19 phenotypes before pregnancy be helpful? The CPIC for non-pregnant people cautiously or offer it as an option. It's not mandatory. And the question is, would that be helpful? Would it be, would this be the next study that you would do, where you would phenotype people ahead of time and then try to optimally, would that help us in our optimal management of dosing people and controlling depression in pregnancy? And the problem is, with SSRIs, there seems to be no correlation between the dose you give them, their emotional response, and their concentrations that you see. And this, we spent so many hours looking at, so who got a dosing change? When did it occur? What was going on with their concentration to dose ratio? What was happening with their PHQ-9s and GAD-7 scores? Was there any relationship to it? And it just confounded us. There was just no pattern that we could see. What was interesting is 10 out of our 47 patients for sertraline, which is 21%, had concentrations below throughout both antepartum and postpartum. Every single one of them was lower than what was considered therapeutic by European standards. So Europe does a lot more therapeutic drug monitoring when they dose their SSRIs. And for sertraline, the therapeutic range is between 10 and 50. 21% of our patients had concentrations below 10 throughout their entire time. 9 of the patients increased their dose once to twice during pregnancy. They ranged across all phenotypes. Only one person had a concentration below 10 prior to this increase. And as I said before, there was no correlation between what was happening with their concentrations and the increase in their dose. One person went from 200 to 225 to 250 in the first half of her pregnancy, and then prior to delivery, she dropped back down to 200 milligrams. There are 2 people who decreased their doses, but the most important thing is that I can say is that there was no correlation that we could identify between how these people were feeling, why they changed their dose, and what was going on within their plasma in terms of concentrations. The initial, although pharmacogenetics helps us understand what's going on with their concentrations in terms of managing women with depression with SSRIs in pregnancy, we haven't figured that out yet. The other things that you have to look at in terms of pharmacogenetics is the actual SERT transporter. So the transporter that gets inhibited by SSRIs, the maternal facing surface of the placenta is covered with them. And their primary job, it's thought, I mean, this is all hypothetical, is that the developing fetus does not make its own serotonin in the early part of gestation, and that these transporters are pulling serotonin out of maternal plasma into the placenta and moving it across into the fetus. And so, does SERT variance affect the exposure of fetal of the fetus to this serotonin? Does it in the presence of SSRIs? So are the pharmacogenetic differences within this transporter, does that affect fetal exposure? We also have to look at, there's a transporter, OCT3, that transfers serotonin from the fetus into the placenta, and our pharmacogenetic variance with that affected. Does that affect fetal exposure? And then we also have to look at P-glycoprotein. Both sertraline and the citalopram are clear P-glycoprotein substrates. The placenta, just like with SERT, the apical surface of that, the maternal facing surface, is covered with P-glycoprotein, and it's a way of protecting the fetus from xenobiotic exposures for whatever them are substrates. But that's a fetal origin, and so does, differences in pharmacogenetics of that affect fetal exposure. And the one other thing that I think is important to talk about is that serotonin is a vasoconstrictor, and another role for the SERT on that apical surface is to keep serotonin away from the vascular supply, the moms within the placenta, because one of the critical important features from an obstetrical point is that the placenta is an AV malformation. It is a low pressure. It absorbs 10 to 15% of maternal cardiac output, and you have to have, when you vasoconstrict the vessels that that go to the uterus that are within the placenta, you are really potentially restricting blood supply to that developing fetus. And so by inhibiting the SERT with SSRIs, what are we doing to overall blood flow and placental development as well? So that gets me to that last point that I wanted to talk about, and I'm almost done. and what we have to think about is not just, the teratogenic effects of drugs or the PK of these drugs, but what does it do to, how do these drugs work, and can that same mechanism affect the pregnancy unit? And I want to give an example of something else that I've been working on, which is another serotonin a drug that involves serotonin. It's not an SSRI, but sumatriptan for the treatment of migraines. Migraines in pregnancy tend to get better because of rising estradiol levels, but that doesn't really happen until a good second trimester, and especially in the first and second, people are still having debilitating migraines, and the current recommendations, I helped write them for ACOG, are that we give acetaminophen and caffeine. that the CGRPs are clearly to be avoided, and sumatriptan is used as a kind of a last-ditch resort for headaches that we can't treat with acetaminophen and caffeine, or that don't respond to metoclopramide with diphenhydramine. But the triptans, the way that they work, and they represent one of the primary treatments for migraines, is that they're an agonist for the serotonin receptor 5-HT1B and D. And in the trigeminal nerves, this inhibits the release of pro-inflammatory compounds. It also blocks the pain signaling out of the trigeminal cervical complex, but it also potently vasoconstricts the dural and meningeal vessels that have previously dilated with onset of a migraine. Because of this potent vasoconstriction, that effect from the triptans, it's actually contraindicated in people with coronary artery disease, because in vessels that are already abnormally affected by atherosclerosis, that additional constriction, because the 5-HT1B receptors are found in coronary arteries, and the vasoconstriction that occurs with people with atherosclerosis has had very significant detrimental outcomes in terms of MIs. Well, so where else are these receptors located? And they've been shown to be in the uterine and umbilical arteries. They've been mapped there when they were kind of looking for like where else are 5-HT1B receptors. They've been shown to have taken in vitro, when you take a segment of the umbilical artery and bathe it in serotonin, it constricts. But there's been no in situ studies done looking at what happens to placental and uterine and umbilical blood flow when you give sumatriptan. So it's very easy to measure that, and this is actually a study I've proposed that we've put in for internal funding in people with recalcitrant migraines that nothing's working and they want to use sumatriptan, that we'll do Doppler studies of umbilical and uterine vessels before sumatriptan, administer sumatriptan, and then at peak times, 2.5 hours later, revisit those studies to see what percentage of vasoconstriction has occurred. And with that, I'm done.